Acute kidney injury is an insult that has occurred to the kidneys due to a systemic illness, critical illness, and/or major surgical intervention. The problem with acute kidney injury is it's often silent. It's not until we see an increase in creatinine or a reduction in urine output, which have been the classic measures of severity, but those are late changes. Prior to that, there is often injury occurring that are not identified until these late markers begin to change. It takes loss of almost 50% of your renal function before you begin to see those things change. If I believed somebody was at increased risk, either due to their underlying disease, the procedure or illness at hand, and/or new biomarkers that would address this issue, I'd be clearly more attuned to the agents I am giving this patient, whether they're nephrotoxic or not, the concentrations of drugs I'm employing, the use of contrast media, the optimization of hemodynamics and blood pressure management. I might get a nephrology consult at an earlier stage to make sure some of the antibiotics aren't impacting negatively the situation. Now, whether that changes the course or not, I'd be aware. I'd be increased sensitivity to this problem. One of these situations where earlier information can really be helpful is in the patient you don't expect a problem with, but is now demonstrating a physiologic change. In some of these patients, the potential to identify those who might be at increased risk of an acute kidney injury with its known morbidity, mortality, and cost would get us to be more aggressive in how we might manage those patients.